At EAU, we had a session that was debating the role of local treatments in a patient who was a little bit older who had some medical comorbidities. In this instance, there was a debate that was discussing different options, including active surveillance, either the role of partial nephrectomy rather than a total nephrectomy, and the role of focal therapies such as thermal ablation, and in my case, the use of SBRT or SABR. What I proposed in my discussion as a proponent for SBRT or SABR, which stands for stereotactic ablative body radiotherapy, is the use of a non-invasive radiation treatment for cure in patients with small renal masses that may need some treatment. In this particular case, the patient was 75 years old and had some medical comorbidities that needed him to have anticoagulation with warfarin, and also had some issues from a cardiac perspective, including atrial fibrillation and a valve stenosis requiring replacement. So in this particular patient, he had some risks for a surgical approach, and we were also considering whether active surveillance could be an approach, in my case, SBRT. The ideal aspect of SABR or SBRT in this situation is I could discuss that the outcomes from SBRT or SABR are excellent and comparable to other local treatments. So in other words, partial nephrectomy, which is the gold standard in clearly operable and fit patients. The evidence to date with SABR is that the outcomes are expected to be control rates of above 95%, even at 5 years. It's totally non-invasive, and the complication rates are lower than the other treatment modalities. So that includes percutaneous ablation or surgery. In this kind of instance, in a patient who may want to have local treatment or is having a tumor, in this case, that was growing quite quickly and may have a risk of metastasis down the track, my argument would be that SABR might be an ideal choice for this kind of patient in the future.